Support for the Journal of Clinical Oncology podcast is provided in part by AstraZeneca, dedicated to advancing options and providing hope for people living with cancer. More information at AstraZeneca-US.com.
Hello and welcome to JCO Precision Oncology Conversations, where we bring you engaging conversations with authors of clinically relevant and highly significant JCO PO articles. I'm your host, Dr. Abdul Rafeh Naqash, social media editor for JCO Precision Oncology and assistant professor of medical oncology at the OU Stephenson Cancer Center. Today, I'm thrilled to be joined by Dr. Mohamed Salem, gastrointestinal medical oncologist and research director at the Levine Cancer Institute in Charlotte, North Carolina. Dr. Salem is the lead author of the JCO Precision Oncology article, Landscape of KRAS G12C Associated Genomic Alterations and Interrelation with Immuno-Oncology Biomarkers in KRAS Mutated Cancers. Our guest disclosures will be linked in the transcript. Dr. Salem, welcome to our podcast, and thank you for joining us today.
Thank you for having me. A pleasure and honor.
For the sake of this podcast, we'll be referring to each other using our first names. So thank you for coming on to our podcast and discussing this very interesting paper. And one of the reasons why we decided to incorporate this is because, as you very well know, KRAS is one of the most common altered genes in cancer. And I'm pretty confident and sure that oncologists, whether it's academic oncologists or community oncologists, have treated patients in different settings having tumors that harbor KRAS alterations. So give us a little bit of a background on where KRAS alterations stand currently and where is drug development in the space of KRAS to give our listeners some idea of why we're interested in this gene.
Sure. No, thanks again for having me. And as you mentioned, KRAS mutation happened to be, I think, by far the most common oncogenic mutation we see in oncology in solid tumor. The problem with KRAS that for long time, there was very much nothing we can do about it. It was, in fact, called undruggable target. Until recently, we start to realize this might not be true. And in fact, we start to see successful effort trying to target KRAS mutation. Currently, there are several KRAS inhibitors. I think the start was G12C. I personally don't think it was anything specific about G12C, but just happened to be one of the first targets that we were able to approach. And the initial result from using anti-G12C therapy that was published in New England Journal of Medicine, I think a year ago now, showed this is visible and perhaps effective.
Thank you so much, Dr. Salem, for that explanation. And being a phase 1 trialist, I personally have seen a lot of exciting combination-based approaches in the setting of KRAS altered tumors, especially KRAS G12C. Now, specifically delving into your paper, given the extensive length and breadth of data that you covered here, could you tell us a little bit about why you decided to use KRAS as an interesting topic for your study and the kind of data set that you chose to explore this question?
What happened once we start to realize how important it is to figure out which KRAS mutation we're dealing with? Because at least in colorectal cancer, it's a very common mutation. Almost like 40-50% of patients with colorectal cancer tumor carry KRAS mutation. Until very recently, we really didn't pay close attention which variant it is. Is it KRAS G12D, D13, or G12C, and so on and so forth. And the reason we didn't really pay much attention for that, because there is nothing to do about it. Like whether patient has this or this variant really was nothing that will therapeutic-wise will have an impact. But once we start to realize now there is a therapeutic option, and in fact, now there is a change in the way we think about KRAS mutation. There is a proof of concept that we actually can target KRAS mutation. We start to pay closer attention to this. And I think this was a paradigm shift in our thinking. So for patients who have KRAS mutation, now we have data showing that KRAS G12C is something we can target, whether with single agent or with combination therapy. But it was a new era for us because most of us realized this is not going to stop there, not going to be just G12C. I think G12C is the tip of the iceberg, and likely the science is going to go forward, try to target other variants. So one of the obvious question was, what are the other variants and how commonly those exist? And which tumor type also carry those variants? Because as we were talking before the recording, for phase one, now it is not like one approach fits all. It starts to kind of like focus on either molecular driven or disease type approach. And it was very important for us to try to figure out, okay, which tumor type carries the most KRAS variant, and within that tumor, which variant are the most common? And this is what we're trying to answer in this paper.
Thank you so much, Mohamed. I look at your data set that you had access to, very large data set of around 79,000 tumor samples and close to 14,000 KRAS mutated tumors. Could you tell us a little more about this data set and how you started with looking at the distribution of KRAS across different tumors, and what were the kind of interesting results that you came across as far as KRAS distribution is concerned?
It's very obvious to all of us now that the field is moving from one size fits all to target approach or treatment target approach. And this is very, very important and very interesting because usually when we do that, we achieve better outcome and lesser toxicity. But the problem that comes with this, that none of us as a one single, even two center, will have enough data to ask and answer questions. And when you are talking about like something like MSI high or PRAF or KRAS, usually it becomes very challenging to one single institution, doesn't matter how big they are, to try to answer either prevalence nor therapeutic approach. Because of that, most of us now start to understand that collaboration is very important across centers and also across nations. So like as you see here in this paper, there was a global collaboration between investigators in the US and in Europe and Austria and other countries. And what we did as a group, we worked with one of the third-party profiling company. Our group tried to answer what is the prevalence, just a very simple question, what is the prevalence of KRAS mutation and what is the prevalence of each variant type in each tumor? And none of us could have answered that question on their own. Because of that, we actually collaborated with one of the third-party companies that they do next-gen sequencing for tumor, and we're able to collaborate with them to have access to that database and answer some of those questions.
Excellent. As everybody knows, NGS is a standard of care testing that oncologists do, especially for advanced setting, to identify driver alterations or therapeutic interventions that may be relevant for patients. So in this data set, it seems you had access to NGS data and tumor mutational burden and PD-L1 data for these tumor types. Could you tell us about the differences in the distribution for KRAS and the KRAS subtypes that you identified in this data set?
Sure. So as you mentioned, we looked actually at almost 79,000 tumor samples that underwent next generation sequencing by our collaborator. And it appears that about 17% of tumor or so harbored KRAS mutation, some kind of KRAS mutation. And then after that, we start to see like G12C, when we start to look at each variant, G12C were about 11-12%, and about 88% of the remaining KRAS mutant tumor harbored some different kind of KRAS mutation. The next question was, in general, in all tumor, what was the most common KRAS variant was seen? I think it mimicked what already out there. It appears that G12D happened to be perhaps the most frequent mutation seen in KRAS mutated tumor, followed by G12V, followed by G12C, and then G1213, and then others. What was very interesting, actually, observation we saw that we were able to realize that the distribution of KRAS variant varies according to the tumor subtype. So, for example, in pancreatic cancer, we could see patients who have a G12R KRAS mutation variant. This was not seen commonly in other tumor. And the reason that's important because maybe that will be something in pancreatic cancer tumor, it will be worth looking at and do therapeutic approach there. But also, I'm sure you're already dealing with this in your clinic quite often. It was interesting, obviously, that lung cancer, non-small cell lung cancer, was the most common organ that they actually carry G12C, followed by colorectal cancer, followed by a very interesting actually observation that was very interesting for us to see was appendiceal cancer. As you know, appendiceal cancer is not a common disease, it's a relatively rare disease. And we're surprised to see some of them actually have G12C mutation. And again, the reason that's important because that just opens the door for possible therapeutic option and in context of clinical trial.
Excellent. Definitely the advantage of having such a rich data set like you did enabled you to look into some of these unique distributions across rare tumors, which makes it very interesting. Now, one thing that I realized in the paper is that these tumors of unknown origin, where you identified or your group identified that they had a certain percentage of KRAS alterations, suggesting maybe their tumor of origin is perhaps lung or above diaphragm, which could have therapeutic implications. Could you tell us a little more about this?
Yeah, this another was a very interesting observation we saw because it is not uncommon for us in the clinic. We get like a cancer biopsy, but we cannot tell where it's coming from. And there is multiple ongoing effort to try to identify that for the obvious reason. But it was very interesting when we looked at those groups that we knew it had cancer, adenocarcinoma, but it was no identified origin. It was the fourth common tumor that to see G12C. I think if you can just make the assumption, I don't think we have proved that, but since lung cancer was the most common tumor that exhibit the G12C mutation, and now we have tumor of unknown origin also, many of them exhibit G12C mutation, we thought this could be a lung primary. As you know, like there is also now a few platforms trying to identify actually the tumor origin based on the next-gen sequencing, but we didn't try to associate it with that.
Thank you for that explanation. Now, one of the other things that I observed is you tried to delve into smoking status very interestingly and how that correlated with KRAS alterations. And as we know, lung cancer, obviously, there is a strong predilection in patients who are smokers, but irrespective of smoking, there can be other alterations that drive lung cancer. But interestingly, in your paper, you identified a unique correlation between smoking and G12C and also found out something on those lines in colorectal cancer, which to my understanding has not been described before. What is your understanding of why that happens? What could be the mutational events that lead to something like that? And how could that be potentially therapeutically exploited?
I think this was one of the very interesting findings we observed. You are right. Just because the nature of the lung cancer, we know like many of patients are either active smoker or prior smoker. So it was not a surprise for us to see that there is some kind of association with smoking status in lung cancer. But to your point, what was really surprising in a way or interesting for us to see actually that association for patients with colorectal cancer. Colorectal cancer, smoking is actually happen to be one of the risk factor like in colon cancer, but obviously not as high as lung cancer. But when we looked at the data, demographic and clinical features, it was obvious actually that current smoking status, whether a current smoker or prior smoker, had an association with G12C. And also with gender as well. Female tend to have more G12C, or G12C mutation was more likely to be seen in female than male. So the fact is that we're able to identify the smoking status and the gender like as more likely to harbor G12C mutation wasn't interesting. I have to tell you, the reviewer, when we submitted the paper for review, the reviewer came back and asked us, is this happen just because you have too many lung cancer and most lung cancer patients smoke? That's why you're seeing that association. And went back and we looked at the data again and spoke with our biostat team in the study, and we're able to actually run the analysis and show that no, it is not just because of the enrichment. It's actually the real association between the smoking status and G12C. It's very interesting to see, at least in colorectal cancer. It's following the same trend in lung cancer.
Right. And one of the other things I remembered when I was reading through your paper in smoking status, I remember this paper that was published in Science magazine 2016, looking at how mutational burden changes in patients that have a history of smoking. But when you connect the dots here, interestingly, it seems like, especially in lung, from what you guys have described here, is that the smoking status impacts what kind of KRAS alteration is present. But at the same time, you didn't see a tumor mutational burden that was significantly higher in G12C mutated non-small cell lung cancer, where you would expect a lot of these G12Cs to be related to smoking. But on the other hand, the tumor mutational burden was not necessarily increased. And I understand you may not have an explanation for that through the data that you've published on, but that was kind of an interesting observation that I had. I don't know if you have any specific comments on that.
No, it's absolutely correct. What we thought that we should see that because the obvious rationale you just cited, but it wasn't. And until today, actually trying to figure out why the disconnect, like because you have people who smoke, usually you expect like PD-L1 is positive, you expect higher tumor burden, but it didn't show at least a statistically significant correlation.
Thank you. And I guess it's notable to mention that you did have some interesting correlations for tumor mutational burden overall and with PD-L1. Could you tell us about that for different KRAS genetic alterations?
There were few papers published before by our colleagues trying also to understand the correlation between G12C mutation and the immune status or immune microenvironment and some biomarker. And I think, at least to my understanding, there was not one consensus. I think there was different finding some degree. So in general, when we actually looked at the entire cohort, regardless of the tumor type, it appears that tumors that carry G12C mutation also happen to have higher PD-L1 expression. What was very interesting that like once we start to look at different tumor type, this was not seen across all tumors. So some tumor did actually carry that, and some other tumor type didn't show that correlation. And I'll be honest with you, I'm still until today I'm not sure why. Is this just a function of number, or actually there is more tumor biology that reflect that? I have to say my own feeling, and that's something we need to study further, that I think it is tumor biology. One thing was also very interesting to us from the clinical side. You have G12C mutation in lung, and you have G12C mutation in colorectal. And in the New England phase 1 study, you could see very clearly that targeted G12C is more effective in lung compared to colorectal. It's the same target, the same drug, yet the response is different once you start to have two different tumor types. So that just got me to think there must be something with the tumor type and microenvironment of the tumor, and also associated co-mutation and other factors that impact that.
I couldn't agree with you more. And I totally have seen that in some of the work that has been published or data that I've been part of, where different tumor biologies or tumor microenvironments, even sites of metastasis, make a difference in how a certain mutation behaves. So definitely something that needs further validation with perhaps proteomic and transcriptomic data to understand functional characterization of the downstream consequences for some of these mutations. And you pointed out co-mutation status. That's a ever emerging question for some of the potentially druggable alterations, whether combination approaches targeting some other co-occurring common co-mutation would have more benefits. Could you tell us about some of the unique, interesting co-mutations that you identified in your cohort that were more common in certain KRAS subtypes?
Sure. I think that's also what was something we tried to look at for the reason I just mentioned. We know that tumor origin and tumor type influence the response and sensitivity to therapy. I think the best example we have, at least in colorectal cancer, is the BRAF mutation. When we saw the BRAF inhibitor having very nice response rate and control of BRAF mutant melanoma, in colorectal cancer, we saw that going to be the same thing, the same drug, the same target, same thing going to happen. And obviously, it was not the case. And this was a lesson for all of us to understand even if it is the same target, if it's the same drug, tumor origin matter. And likely that because of the associated co-mutation that will influence the pathway of the tumor and perhaps either the sensitivity to the drug or maybe resistant to the drug. So it was very important for us to look also at the associated co-mutation. And I think one of the key one, and perhaps you will comment on this more than me, but the KEAP1 gene was likely to be mutated in those tumors who have G12C mutation than other. Other one was STK11. And there were like few other ones independent in which tumor type. But KEAP1 was very interesting finding for us too, because as you're aware, it's important, at least in lung cancer, and maybe will impact therapeutic approach too.
You're definitely right. It is important in lung cancer, and there's data that has shown both the STK11 and KEAP1 tumors have inferior outcomes to checkpoint inhibitors and are partly involved in metabolic reprogramming of the tumors. So there's definitely emerging targets that are trying to see if combination approaches in STK11 mutant lung cancer will demonstrate some level of benefit. But I think the co-mutation status would potentially have some sort of impact. But again, functional studies that help us understand what are the downstream consequences of one mutation versus another need to be further performed to get a better understanding of this space. But I think this is definitely interesting work and very interesting results. Hopefully our listeners will feel the same and maybe even try to go through the paper to understand some of the other additional results that you have published as part of this extensive paper. We thank you on behalf of JCO Precision Oncology in submitting your work to JCO Precision Oncology. And hopefully you'll consider us for further subsequent work in this space. Thank you so much for being with us today.
No, thank you for having me. And actually, on behalf of my co-authors, I also wanted to thank JCO Precision Oncology for their interest in our paper, and of course for the reviewers, because with no doubt they actually made our paper a much better one. So thank you for having me today. Thank you for the entire team.
Reviewers definitely remain the people hidden behind the scenes who help in getting work refined and eventually published. So thank you again, and thank you for listening to JCO Precision Oncology Conversations. Don't forget to give us a rating or a review, and be sure to subscribe so you never miss an episode. You can find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.